presentation of the AIM hypertension bundle. Welcome, Ms. O'Brien.
Thank you so much, Dr. Ortiz, Dr. Ortiq, and I appreciate the invitation to speak with you all today. Our neighbors to the south, I grew up in El Paso and Houston, got my bachelor's of science in nursing at UT Houston. So Texas holds a special place in my heart. And if you'll look at the next slide, before I get started, I just want to share the vision of the Oklahoma Perinatal Quality Improvement Collaborative is creating a culture of safety, equity, excellent safety and equity in perinatal care. Next slide. And just to provide you with some references, if you see anything that you'd like to access, you can go to our website, which is here, and it was actually updated this morning. So it may have a different look than what you see here. Next slide. Just wanted to show the objectives for the talk that I'm giving today. And looking at the next slide, I want to share there that when we talk about these evidence-based approaches to addressing disparities in care and outcomes with peripartum hypertensive disorders, looking at the next slide, one of the best ways that evidence has shown that we can do this is to standardize our practice. And Dr. Rana talked previously about standardizing this practice for postpartum women. I think after hearing her presentation, we need to do a better job of that in Oklahoma. But it looks like for Texas, you all have done a great job so far in the work that you're doing, and I'm sure you'll have more success with the implementation of the hypertension bundle. The main thing that we focused on in our work with the hypertension bundle implementation was this timely treatment of severe hypertension. And if you'll look at the next slide, I'm not going to go into detail on these, but wanted to provide with all of you all, these are the recommendations of our professional organizations, and there's a lot of support for treating these blood pressures of the severe range within preferably 30 minutes, but up to 60 minutes. So the ACOG practice bulletin, next slide, the ACOG committee opinion here. And then one here that I think is very helpful to support the work that we do is this study that came from California, where they looked at the causes of death related to systolic hypertension and preeclampsia related mortality and stroke in California, and found that stroke is the major cause of maternal mortality associated with preeclampsia or eclampsia. And that was also found that these women most often did not receive timely treatment when they had severe hypertension. Looking at the next slide, just recently in our new, next slide, please. In the obstetrics and gynecology that is current for February of 2021, there's a study looking at this semi-autonomous treatment algorithm and the improved treatment and outcomes they saw. And then the next slide, there was also in this same publication of the current Green Journal, looking at racial and ethnic disparities in reproductive health services and outcome. If you look at the next slide, here on this second column, I will read, establishment of management protocols by hospitals and medical practices for the management of conditions such as postpartum hemorrhage, hypertensive disorders of pregnancy, and maternal cardiovascular disease will lessen the disparate care provided to women of color, increase standardized care, and improve maternal morbidity and mortality. So it really focuses on, with these maternal safety bundles, this standardization of care. If you look at the next slide, I want to share with you all some resources that are available on our website. We have a page dedicated to AIM, and this webcast that you see here for treating maternal hypertension is a great thing that you can use for your education for your nurses and providers, where the authors of ACOG's executive publication on hypertension in pregnancy talk about treating maternal hypertension. And it's just a 10-minute video that they can watch. So I'd encourage you all to use that. And looking at the next slide, this is our page related to the bundle on hypertension and pregnancy. And we have broken all the different R's down and have different resources available for each of those. So feel free to use our website and go to these resources to help in your work. I do also want to mention, if you'll look at the next slide, AIM just recently updated their data metric related to timely treatment. There was a little bit of confusion with the first measure. If you see the one that's not highlighted with the original metric, the denominator talks about persistent twice new onset hypertension excludes these women with an exacerbation of chronic hypertension. It's a little more clear in the updated version. Talks about this, that it is an acute onset severe hypertension, and that it does include these women with preeclampsia, gestational, or chronic hypertension, because we had a lot of questions on that and a lot of providers that were resistant to treating women who had chronic diagnosis or were being treated for chronic hypertension. So this is something that is very strongly supports that. And also just a little bit with the numerator, you can see it makes things a little more clear. So I think this will help you as you're collecting these data. Our mantra in Oklahoma, if you look at the next slide, is believe it and treat it. There's a case where you do not treat a woman with severe hypertension readings should be extremely rare. And providing, especially, many of these medications some of the medications can have some contradictions, but a dose of the immediate release nifedipine is probably not likely going to have adverse reactions for anyone. So believe it and treat it. If you look at the next slide, just wanted to point out the website. You all are probably familiar with this, but just in case you're not, with the safehealthcareforeverywoman.org from the Council on Patient Safety and Women's Healthcare. And this also includes all of the AIM resources. They do have some that were just recently updated, like last week. So I would encourage you all to go and visit and explore that. The AIM data portal is accessible through this website, and I want to share a little bit of data from Oklahoma and the work that we've done with the AIM collaborative and implementing the severe hypertension bundle. If you go to the next slide, we talk about disparities, and Dr. Ollier mentioned disparities, and these are data related to severe maternal morbidity by race. In Oklahoma, we definitely have disparities for these African-American women, and also for Native American women. Our percentage of population in Oklahoma, actually, we have more Native American women than we do Black women. So we see these data, and these data, if we took them and analyzed them some, broke them down, and we are seeing a decrease in these disparities. We are awaiting some guidance on the CDC because we know that some of these could be affected by the changes from ICD-9 to ICD-10 and the coding for blood transfusions. So I do want to share with you that yes, we have these disparities that exist. And until we address these, we will not see the changes. So if you go to the next slide, just an overview of our data. We have seen a timely treatment of severe hypertension process measure increased by 46% since we began this work. And the next slide shows that we have seen severe maternal morbidity among preeclampsia cases decreased by 42%. And the next slide, we can see that for all delivering women, the red line shows when our work began that we have seen severe maternal morbidity decrease overall by 23%. But when we look at these data, it's important for us to remember that each of these is a patient with a family. She's a member of our community, a wife, a mother, a daughter, and a sister. And we need to realize that they all have a story. Every data point is a story. So I want to focus the next portion of my presentation on what we're doing when it comes to listening to women and families. We decided in Oklahoma we needed to walk the walk. And so we, if you look at the next slide, we have added a maternal peer navigator to our staff as a full-time paid member of our staff. Sarah Johnson is a patient who experienced severe maternal morbidity related to hemorrhage, and she is also a member of the Cherokee Nation. So looking at the next slide, we can see the areas of focus and the strategies that we're using for Sarah to amplify the patient voice in our work and partners' work, so that she can provide the patient perspective to the work that we do, to also educate providers, partners in the community through her story. We are using the CDC Hear Her campaign that you heard this morning, Dr. Barfield mentioned. We're providing presentations to hospitals, to other partners such as state agencies, community agencies, and also within the community. For example, I just presented recently to the League of Women Voters. We want to create that awareness among the community, among patients, among friends and families, to understand when to seek help and how to seek help. And then we're also creating a patient network. So we have other patients that are joining in this work, have provided us with feedback on this, and will also at some point begin working with local hospitals. The next slide, we can see this is Sarah and her baby Mila. And really what we really want to emphasize here, that it is the importance of listening to women. And if you look at the next slide, you may have heard of the deadly Ds. Dr. Main talks about denial and delay that can cause maternal death or morbidity. Eleni Tsigas has added dismissal, that as providers, we often dismiss concerns. So we really want to work to empower patients and give standardized education on maternal warning signs and post-birth warning signs that we are encouraging, and I'll tell you a minute exactly a little more detail how we're doing this, starting with the early education during prenatal care visits, reinforcing again during other visits and at the birth, hospitalization, and discharge. And really giving them permission, opening the door and telling them, I want you to talk to us and tell people if you have problems. We want to partner with patients to encourage a collaborative relationship, creating this safe, inviting communication environment, and then for the healthcare providers to listen to women. It is our duty to listen, to investigate, as our patient speaker, April, talked this afternoon. We need to find out the why, investigating, taking action, and providing information and or reassurance. That is our duty to our patients. Looking at the next slide, how are we empowering women and families through this education and partnership? Next slide, we have here the CDC Hear Her campaign that you heard Dr. Barfield mention earlier. And the next slide shows one of the pages on this. I would really encourage you to visit this. They have pregnant and postpartum women resources for patient partners, friends, and families, and also for healthcare providers. What we are doing, if you look at the next slide, we're asking our providers to print off the PDF of this urgent maternal warning signs. Looking at the next slide, there's also a pictorial, and putting it on the wall within an exam room so that you can use this when you're educating your patients, and also giving them a hard copy of this. This is for them and their families, and to ensure that you tell them also how do you seek help if you have concerns, and opening that door and giving them permission, encouraging them to seek help. And then we reinforce this again at the postpartum visit with the A1 post-birth warning signs education program. And we are also encouraging hospitals and to work with the emergency department on this as well, so they recognize these women. A couple of other resources before I'm finished, we did create, if you look at the next slide, sorry, that was the A1 post-birth warning signs. The next slide is a resource that we created for helpful post-birth resources. We thought, what are some places that many women would be seeking help for? We didn't want to make it too busy. Many women have questions on breastfeeding. This new mom health and family support is really excellent, looking at all the different things that women may have concerns about. For example, here they connect with the Preeclampsia Foundation. We are also encouraging hospitals to use the Preeclampsia Foundation educational materials. The mental health support, encouraging them to go to postpartum.net. And then we have just recently launched a web page this morning with post-birth resources from our website. And then we provided a patient an email here that they can email with further questions. The other thing that we support this with is providing this clinical summary. If you'll look at the next slide, we are encouraging the provider, when they're providing education about the birth, so especially if there is an adverse event, that they give the patient this clinical summary describing what happened, so the mother has and her family has an understanding of what happened. They know they have this to carry home with them that they can use in reference if they need to seek care in the future, and that they have also information on their follow-up visits and how to seek help. Looking at the next slide, I did this before we had this launch, so did want to say we have a patient-facing webpage that was launched today with additional resources. So thank you all. If you look at the next slide, I appreciate, again, the opportunity to talk with you all today, and here's my contact information if you have any questions and would like to reach me.
Thank you, Barbara. And before you mute yourself, I'm breaking my own rule. Do you have materials available in Spanish language? I want to make sure that question gets answered.
Great question. We just have launched these within the past couple of weeks, so we are getting these patient materials translated, the ones that we're creating, the Council on Patient Safety and Women's Healthcare, and the A1 resources are in Spanish.
Thank you very much. And thank you for your presentation. The A1 post-birth warning signs is an example of an escalation type of instrument. It's a tool to teach women as well as their families what is normal, what's not, and when you should escalate if you have concerns. Our next presenter is Nicole Purnell. Ms. Purnell is the Mama's Voices Coalition Program Manager for the Preeclampsia Foundation. In that role, she provides technical assistance as a subject matter expert as it relates to effective patient engagement strategies infant loss, and hypertensive disorders of pregnancy. And she also serves on several national committees, including the Executive Committee for the National Networks of Perinatal Quality Collaboratives. Her lived experience includes surviving HELP, placenta abruption, and infant loss. Prior to joining the Preeclampsia Foundation, Ms. Purnell was lead volunteer for over 10 years with multiple roles within the organization that resulted in being awarded the 2012 Volunteer of the Year Award. She lives in Sanger, Texas with her husband and 5-year-old daughter, and wants us to mention her 2 dachshunds as well. Nicole is going to present on best practices for shared decision-making and patient-centered care for women with peripartum hypertensive disorders. Welcome, Ms. Purnell.
Thank you, Dr. Ortiz. Thank you for the introduction and for TCHMB for having me today. As Dr. Ortiz mentioned, I am the manager for Mama's Voices Coalition, but I also have the lived experience with preeclampsia and health. Today, I'm going to be sharing with you actually about my own personal experience with both my pregnancies, and just to compare them and show you having an honest look at where there were opportunities for improvement. I will start off by saying that I love my OB and that she handled both of my deliveries. Next slide, please. So some background information that we hear from patients. I wanted to share a little bit here on both of them, but we often hear patients wondering about the amount of stress, if the stress that they had, if that impacted their pregnancies, if that contributed to their outcome. We know that more is becoming known on how stress impacts our bodies and how historically marginalized populations have been carrying that burden for generations. So I just want to share a little bit about my personal stress points. These do not compare to other people's stress points. I'm not trying to have a comparison, but I just wanted to show you a perspective here at the background. Both my pregnancies with Cooper and Lorraine were about almost 10 years apart. I was 23 years old when I had him, and I was 33 years old exactly on the date my daughter was born on my birthday. I was married with the same husband. Some people ask that question, had the same associate's degree. We both worked for Fortune 100 companies when I was pregnant with Cooper. When I was pregnant with Lorraine, I still worked for the same company, but we weren't doing as well. And my husband had gone to a different company. We had private insurance through our employers through the entire time. We did have a significant deductible that did play a part in some decision-making, I feel like, with Cooper for sure, with Lorraine as well. And I had the same really stressful job. One thing that was done differently, though, was that it was just managed differently. My employers and our team were very supportive in my second pregnancy to making sure that we had a different outcome. Next slide, please. Just to show you little pictures before and after, we were babies when I got pregnant with Cooper, and that was about 31 weeks pregnant. I felt really big. I felt huge, swollen. Even though if you had mentioned swelling to me, I would have argued with you. In fact, I did argue with people. I was not that big, even though I knew I was as large as a house. Next slide. With Lorraine, I was feeling pretty sassy before I got pregnant with her. And even though we call it like prego nose, I had a little bit of a swollen nose over there that was from my baby shower with her. I still didn't feel as huge as I did with him. I was able to still fit into a booth at a restaurant, unlike I could when I was pregnant with Cooper. Next slide. So my healthcare provider team, I spoke about how I had the same OB. With Cooper, I started seeing my OB right about 8 weeks. I have PCOS, and so we thought it was a little bit farther along in my pregnancy than I was because of my irregular periods, but it was about 8 weeks when I started seeing her. She was pregnant at the time as well. So I started seeing a midwife in their practice when she delivered. So at 28 plus 4 and 30 plus 5, I was seeing their midwife. And then I started seeing my OB again at 32.5. So what happened in that time period of being out and seeing a midwife, this lack of continuity of care, and I can't blame her for having a baby, like there's a work-life balance. But what happened was there was a different clinic, they had a different clinic in their practice when I was seeing the midwife. And I remember arguing with her. She was saying, "You've gained too much weight. You've gained 12 pounds in 2 weeks. This is too much." And I was arguing with her, like, no, it's not been 2 weeks. It's been 4. And I was right. It was 4 weeks, but I did have weight gain. And she'd even commented as well, like, "Oh, you have some swelling in your ankles." It was kind of wintertime, so I had socks on and they were cutting in around my calves. And I felt really scolded by her. And so my next appointment, when I saw the same midwife, I decided I'm just going to wear my husband's socks. Like, I'm just going to wear bigger socks. I'm going to show her there's not going to be any indentation in my leg this time. And it just felt like I was being put down. And I didn't understand why they were asking these questions. I didn't understand why I was being asked, have you had visual disturbances? Have you had a headache? Do you have pain underneath your ribs or up underneath your bra strap? I did not understand the significance of that. With him, I was put on bed rest at 33 plus 5. Actually, going back to that 32-week appointment, my OB came back that day. I remember sitting in her lobby waiting on her for about an hour because she'd had a delivery, and sitting there with my feet up, went in to go get my blood pressure taken. I've been fighting a cold, so I was taking some Sudafed. That was really smart. And my blood pressure was 160 over 110 at that appointment. So what happened was I got sent over to L&D, had an NST, was sent home with a 24-hour urine to do at home. There were no blood pressure meds given. It also, keep in mind, this was about 15 years ago, so before some of these protocols were put in place. But knowing now, that would have been, treatment would have been necessary at that point. That next week between that appointment, I got put on bed rest. I was not a very good patient on bed rest. All my friends were not good examples necessarily of what that looked like. I had a BPP scheduled on the day when I was 34/6, and I woke up in the middle of the night with severe abdominal pain. And when I reported to the hospital, we could not find a heartbeat. So that ended with a placenta abruption, and I was well on my way down the road of help when I arrived. But one of the things was the on-call OB, she didn't listen to me. When I came in and I was complaining of the amount of pain that I was in, I couldn't even form words completely. I was in so much pain. And I told them, I have already been diagnosed with preeclampsia. I had the pressures. I had a little bit over the criteria at that time on urine. And I'm looking at the monitor and I can see my blood pressure is actually normal, like below normal. And that's not right. Something's wrong. And I'm in excruciating pain. And she was not listening to me at all. I feel like that part of that probably contributed to the extent of my outcome and how sick I got. With Lorraine, we had a fertility treatment. So I was seeing an RE until I was about 8 weeks. I started seeing my OB about 11, and my MFM, who's on this call today again, started seeing her about 16 weeks. So we were bouncing back and forth. Every 2 weeks I was in her office, or then I was in my OBs, back and forth. We were keeping up with growth scans and BPPs on a very regular basis. We had a plan when I went into that pregnancy, which really helped. The plan was that we were going to stay on top of it. And we're going to monitoring it very differently. And we really just wanted to get to 33 weeks. If we can get to 33 weeks, we felt like we would accomplish something. And if things started getting haywire, we were done. We really didn't think we'd get as far as I did. We got to 33 weeks. There was no issues going on. 35 weeks, I was more pregnant than I'd ever been. Still no issues going on. So about 36 weeks, we're like, okay, we're starting to get a little nervous, but let's do an amnio and see if we can go ahead and deliver. And there weren't any indications that came back inconclusive. So we didn't deliver. So we had a scheduled C-section right on the dot at 37 weeks, which happened to be on my birthday. Next slide, please. These are my two babies. With Cooper, just talking about education and where I found out my information. Really books. Back then it was What to Expect While You're Expecting. Like, that was the pregnancy Bible. And that was really the only one back then. I looked at that book a lot, and I looked at that book and there was not a lot of information on preeclampsia, on pregnancy complications in general. So if you go back and you look at it, there's probably less than half a page. And you think, if there's not that much information on it, then it must not be that big a deal. I got information from my friends that had pregnancies already. I was not getting information from my mom. We just ended up arguing about it. And that is my one picture of my son, Cooper. With Lorraine, I had been a volunteer, like she said, for already 10 years with the Preeclampsia Foundation. I knew exactly where to get the information. I knew the people to go to get the information. In fact, at my 10-week appointment, I was sitting in a CME in Minneapolis with some of the top experts in the field of preeclampsia. So I also had all my preeclampsia friends that were there to support me as well. I still wasn't getting information from my mom because she doesn't understand preeclampsia. Next slide. So some medications and some things that were done differently with my pregnancies. With Cooper, I was only on prenatal vitamins. I was taking Claritin for my allergies and made that horrible mistake of taking Sudafed. With Lorraine, I was on my prenatal. I was on low-dose aspirin already because of the fertility treatments. We decided to go ahead and add a small dose of labetalol just because I had that chronic hypertension label beforehand. It did start on Zoloft. I felt it was a little bit necessary for myself, so I didn't end up taking out a coworker. And also my pressures react pretty strongly with my anxiety and my stress. So we went ahead and started on that. We felt it was worth it. And I was also on metformin. About that time, there was a study coming out of Australia that was showing promise in using that to prevent preeclampsia. Whether it did or not, I'm not sure if it actually contributed, but we were concerned about my history with PCOS and not wanting to have gestational diabetes. So that was why we started on that. And they was all, except for the Zoloft, the entry level starting doses for these. So if you want to find out more information about the aspirin, the next slide is going right back to what Dr. Rana was talking about in the Ask About Aspirin rack card that can be handed out. Next slide. Blood pressure monitoring. I know there's been a lot of discussion about this in the chat. And so I just wanted to talk about what some of the differences were in my pregnancies here. With Cooper, I started monitoring my pressure at home when I was about 32.5, right there when I had that, like, your blood pressure is too high. We could not afford a new cuff at the time. So I got a hand-me-down. I got one that looked a lot like this. It was semi-automatic. I got it from my mom. You had to pump it up. The little plug at the bottom came out and I couldn't fix it. And so I didn't even try to get a new one. Like, I didn't know what I was doing. And I thought, well, at least it's come out and I don't have to fuss with this anymore. And I was not taking my blood pressure correctly. I was not taking it consistently. So now that's different. With Lorraine, I had my blood pressure cuff there. It was permanent accessory on my couch. I took it often. I also texted my OB my pressures if they were getting too high. She'd given me her cell phone number in confidence that it wasn't going to get abused. So as you can see, there's one of my dachshunds. He liked to steal my cuties, but my blood pressure cuff was always nearby. Next slide. There's some tools that you can add to this. Dr. Rana mentioned some of them as well. And this page goes along with the cuff kit. I see comments in the chat about the Preeclampsia Foundation's cuff kit. This does have a link to this page, which is preeclampsia.org/blood pressure. This is a video that was put together last year to show patients, really for them to understand how to take their blood pressure at home accurately. This has been a very fantastic tool to use and to share with patients out there that you're giving cuffs to. Maybe you're getting through the cuff kit or through a different area, but they can have this same information. This page has a ton of information and I'm going to share it with you. Next slide, please. One of the things that's also on this page, and it's really similar to what my OB provided me, there was little smiley faces. She had a frowny face, smiley face, and then a really mad face. The one thing that's different on this that she had given to me was if I was in those red ranges, was to take labetalol and call me on the way to the hospital. So we had a great communication. Again, like, she gave me her cell phone number and I could text her what my pressures were. We kept up with it, especially as closer when we got to my delivery, we were keeping in contact with that. But they were not in a range that we needed to induce. In fact, they were just getting a little bit creepy at the end. Next slide, please. This is another part that goes into the same page on the preeclampsia.org/blood-pressure. Is just more information for patients on how to take their pressures properly at home. A lot of this also, I'd say, is maybe good advice in some clinics. Oftentimes, you know, have a nurse is trying to have a chat with you while they're taking your blood pressure at the same time. And it's really hard to sit there and ignore them because I know better. And I shouldn't have a conversation with them when I'm doing my blood pressure. Next slide. So these are the last little bits I want to share with you, just some pictures. And I hope that this leaves you with some passion today, not just on my experience and what happened with me and the differences in my care, and that I was able to be a full participant in my daughter's pregnancy. This little bear in all these pictures is a bear that we made out of my son's nursery set. And these are the pictures that we have them together. So she understands what this bear signifies, and she knows about the brother that she didn't know. But I really want you to feel this and to see these pictures and to challenge not only yourself, but those that you work with, those that aren't here today, that they also, and hold them accountable so that they also are taking care of moms and they're listening to moms and they're treating them when they should be. I think that that's really important, that they're heard and that they get that treatment. So just to take these with you, she is sassy and 5, and we've been home together for 2 days straight because school's been canceled. Next slide, please. And thank you again for having me today. If you want any more information about myself, my story, my experience, or about how to work with patients and engage them, we've had a fantastic turnout today with the patients on the panel earlier today, as well as myself. And thank you, Dr. Artique, for inviting me today.
Nicole, thank you so much both for presenting the work you're doing as well as sharing your story. Stories really are motivating for us and remind us of how much work we have to do. We're almost out of time. There was a question in the chat regarding a participant who works at a pediatric hospital and said that the majority of their patients have moms who live really far away. And she wanted to know if any of the hospitals had a program or partnership for moms to be followed locally without having to drive back into, per se, the medical center or a larger urban setting. And that's a big issue for Texas, because we do have a lot of counties that don't have adequate access to even primary care. I see Nicole nodding.
I was like, yeah, does Dr. Epps want to answer that question?
Oh, I saw that comment as well. I think those are important things that we can work on going forward with the hypertension bundle. It's telling me my internet is unstable, so I'm not sure if you guys can hear me. So I guess I think there's a lot of work to do surrounding those kind of partnerships. And I think that's a longer thing than we can probably cover in a minute. But I think more to come on that in the future. Carla, I know that we are supposed to be ending fairly soon. I don't know.
Right. So I would like to
any last minute
right?
question.
I think that we won't ask any more questions because we're at the end. We had hoped to cover for all of the panelists, just to quickly share if they have any suggestions on how to build trust with communities of color as we implement these programs. And so if Carrie, if you want to allow them that opportunity, otherwise.
Absolutely. Nope. Totally.
So if Dr. Rana is still on the phone, if she wants to give a stab at it, and then we'll go in the same order that you presented.
Yeah, thank you so much. So I agree. I mean, I think, and to answer even the previous question, I feel like all of us who are in, in any position as physician or caregivers, I think we need to really look at our local systems a little bit and see what will work, because I feel sometimes things that I think even internally, I feel like, oh, this is a great idea, and it may work in one situation, but it may not work in the other situation. So I think, like Dr. Epps was saying, this is something that I do agree that we have to think long term in terms of like, what is the best solution for the patient that you are caring for, rather than just bundling all of them into one thing, right? So telehealth may not work for everybody. Coming to the clinic may not work for everybody. Going back to their doctors may not work for everybody. So I think some sort of a kind of constant evaluation of what you're doing will be helpful. Now, to answer this question, yeah, I mean, of course, engaging, people, especially Black pregnant women, it's very hard. I mean, sometimes I see these patients and I'm like, wow, they're living such hard lives. I mean, they're just not the medical problems that they are facing, but at least in South Chicago, we have so many, barriers to their care, their transportation, their family situation, the, care of their babies, their father of the babies, the gun violence. I mean, everything is just like against our pregnant patients. So I think having that at an individual level, I can tell you, having that time to at least listen and give them, Nicole, I also give a lot of my patients my own cell phone, and I can tell you, like, nobody abuses it. In fact, they always they always say, oh, Dr. Han, I'm so sorry, I'm calling you, but and it always ends up with something good. Like, if it takes me 2 seconds, I'm like, sure, do this, do that. I mean, rather than her telling her story to everything else. So I think at an individual level, having time, and I know it's hard as a physician, and we are like, in clinics really busy, to listen to the patients. And sometimes it's only 5 minutes and sometimes it's longer. I think that's one of the things that we can all do is really listen to what the other person is trying to say. And education, at least I believe in education. I feel like educating patients and their care and their family members. And I even say even a janitor is important. I mean, even the person who is in my labor and delivery, everybody knows about preeclampsia and that I'm so passionate about it. So I think educating as many people as we can, and this is a great forum to do that too, I think will also take us closer to reduce the disparity.
Thank you. Barbara?
Yeah, I will just mention certainly the listening. I think if women and families feel they're being heard and you follow up on their concerns, then that will enhance the trust, and having the communication as an open line of communication also helps. The other thing we were going to do pre-pandemic, and we've had to pause, was start having community dinners between the patients in a community and providers, where you just have a dinner together. There's no kind of program where you're trying to give them education per se. There it could be, but it's sitting down together and talking and getting to know each other as human beings, and finding out about each other and learning. And I think that that's something we hope to do in the future in Oklahoma City and also in Tulsa. And, we're starting some pilot projects with that as soon as we're able.
That is an incredible idea. I think I love that and can't wait to hear more about it. Nicole?
I love those ideas as well. I think part of it is, there's a big push on patient-centered care, and meeting patients where they're at, and knowing what they have available. You're not expected to know it all, but being able to ask the questions to make sure that you are meeting them. Do they have internet service? Do they have a cell phone that can send you messages and communicate with you, whether it's calling you or text message? But really looking at your patients as people, and how you can help them out with wherever they're at in their lives. And there's just a lot of different opportunities. It's not a one size fits all for anybody. And so having that, and I do appreciate my OB giving me her cell phone number. I know that doesn't happen with everybody. I also had all 20-minute appointments with her. There's like a turn, you got to turn patients through. But I had 20-minute appointments with her every single time. And we made sure we blocked them off. So everybody in the office knew she gets 20-minute appointments. She sees an OB every appointment. I have nothing against midwives, but I wanted to see an OB. So just some things like that to be able to make sure that they're being heard. Education is very important, to know why you're asking, why do they have headaches, or why are they doing these things? Otherwise, you don't realize how important it was. No one ever really told me how serious preeclampsia could be. I just thought I'd be like, deliver a couple weeks early, put your feet up, and that was it. I had no idea what it could lead to.
Well, thank you again to all our panelists. I think this has been a really excellent discussion, and I hope that our participants have had opportunities to ask questions as well as to exchange ideas. I think I'm supposed to kick it back to Dr. Epps.
Yes, thank you, Carla. I was going to say, I got so drawn into just how good each of the presentations were that I found it hard to cut you all off. So thank you so much for everybody who stuck with us those extra few minutes. I certainly think it was worth it. And I thank our entire panel for sharing such thoughtful, emotional, and strategic approaches to dealing with hypertension. Thanks for joining us today. 2 quick reminders. To receive any continuing education credits. This is the link to go on and to be able to do your post survey and achieve your credits. And then we are really hoping to have you join us again tomorrow for day 2. It starts at noon Central Time. And then as a further reminder, Thank you. As a further reminder, our summit for next year is already in the works. We hope to be able to join each other in person, but we'll see what the next year brings, and that'll be February 16th to 18th. Again, thank you to all of our speakers. Thank you to all of you for participating, and we hope to see you tomorrow. Thank you so much. Bye.